that yesterday we have discussed about the foundation of allergy investigations, in which we really discussed that what is the rationale, what is the basis of total IgE, what is the basis of specific IgE, what is the basis of component result diagnostic, and then we also discussed about eosinophilia, that how eosinophilia approach should be done, and then thereafter the most important thing about clinical history. Now we all understand that when we have taken a deep history, thereafter we definitely require certain tests. In vitro tests have been discussed yesterday. So today we will be discussing about in vivo test. And among the in vivo, the skin prick, patch, depending upon different immune mechanisms. And then thereafter, we will also be talking about something which is upcoming, which is probably the next step, which is BAT and probably a newer version called MAT. And then we will also be discussing that this much is existing right now in our plate, but what else we can probably expect in the future in the 5 years or 10 years down the line. So without wasting much time, let us invite Dr. Sinchana Bhatt. Dr. Sinchana Bhatt is the leading pediatric allergist from Mangalore, and she will be moderating today's session. Dr. Sinchana, welcome, please.
Thank you, Dr. Neeraj Gupta, sir. And this is an excellent initiative by the IAP Allergy and Applied Immunology chapter under the leadership of Dr. Neeraj Gupta, sir, a dynamic pediatrician and allergy specialist from Delhi who is leading our chapter. And this webinar series, this arrangement of these webinar series, especially is going to help each and every one of us who is practicing both pediatrics and allergy. So, without much ado, let us welcome the first speaker for today's session, and that is Dr. S. Alairaja. We are extremely privileged to have him on this platform. He is a pediatric pulmonologist and allergy specialist and an associate professor in the Division of Pediatric Pulmonology at Sri Ramachandra Institute of Higher Education and Research, Chennai. He is also visiting consultant at Surya Hospital and Kaveri Hospital. And he is a very well known pediatric pulmonologist and allergist in Chennai. And he's also a faculty for various modules such as the ATM module, the Casper module, the FLIP module, and the TIPS module. He's a great researcher and an academician who has various publications and chapters to his credit. So we welcome you, Dr. S. Ilaiyaraaja, sir, on for this to speak on skin prick test, the art, science, and interpretation. As we all know, this is the cornerstone of allergy evaluation, the most important test for evaluation in allergy, and it is a privilege for us to have you here. Welcome you, sir.
Thank you, ma'am, for your kind words, and I extend my deepest gratitude for our chairperson, Dr. Neeraj Gupta, for giving me this opportunity. Shall I share my slide, ma'am?
Yes, sir, you can share.
Yeah, is my slides visible, ma'am?
It is visible, sir. Can you please do it on the slideshow? Yes, perfect.
Yeah, so we're moving, no slides?
Yes, they're moving.
So good evening, one and all. And today's topic of discussion will be skin prick test, the art, science, and the interpretation. So the outline of the presentation will be the historical background. For any condition, we need to know a little bit about the history that makes it interesting, and the art of skin prick testing, the science behind it, the procedure, the interpretation, and few case scenarios for understanding of the topic. Right. So coming to the historical background, so in the year 1867, when hay fever was widely prevalent in UK, a Manchester physician named Blackley, he first demonstrated that pollen extracts caused skin wheals when applied to scratch the skin of hay fever patients. So this was the first instance of a crude skin prick testing. Later in 1912, Dr. Schloss, a physician in New York, he demonstrated scratch test. He demonstrated that when antigens are placed on the scratched skin, he demonstrated a wheal and flare reaction suggestive of IgE mediated allergy in a patient. And subsequently, in the year 1920, various scratch tests were used to diagnose immediate hypersensitivity to inhalant allergens. This was by Lewis and Grant. In the year 1967, Pepys et al. In London, they described the standardized skin prick test using a defined allergen extract and using specific lancets. So this method is continued even today in the modern era all over the world. So the father of skin prick test, you can say it is Pepys, and the year of invention was in 1967. Right. So coming to the art of skin prick testing. So first we will brush up the basics. What is allergy? Allergy is a Ig mediated hypersensitivity reaction to an allergen, which will result in eosinophilic inflammation. So this immune system is overacting to substances that are usually harmless. And what is an allergen? It is a protein that can be either inhaled or ingested or through direct contact. It can cause an allergic reaction in a sensitized individual. So what are the different types of Ig mediated allergic reactions we know of? One is bronchial asthma and allergic rhinitis, which are very common. Apart from that, food allergy, anaphylaxis, all are Ig mediated allergic reactions only. Right. So we need to understand the mechanism of allergic reaction, even though it is very simple, but it is very important that we know the basics, right? So there are two components of Ig mediated sensitization. Since Ig mediated allergic reaction, first is sensitization, second is re-exposure reaction. So on first exposure, when the allergen comes into contact with the antigen presenting cell, it activates the Th2 cell, which which in turn activates the B cell and causes class switching and causes a release of IgE. IgE can exist both in free form as well as the bound form. So IgE is also bound to the Fc receptors of the mast cells. So once it is bound to the mast cells, it is now ready for the next antigenic exposure. So on the next antigenic re-exposure, this antigen gets attached to the IgE and then causes degranulation of the mast cell, releasing a lot of chemical mediators like histamine, leukotrienes, and other mediators. So this is the basis of Ig mediated type 1 hypersensitivity reaction. So to demonstrate that there is an allergen implicated in the allergy in the disease, we need to demonstrate that allergen specific allergen specific Ig to that particular antigen. So what are the ways to detect that? So there are two types of tests. That is, one is the in vivo testing, second is the in vitro testing. So what is in vivo testing? Anything that is performed in the living organism is called in vivo testing. What is in vitro testing? Anything that is performed outside the living organism, like in test tubes, glass tubes, bottles. So anything that is conducted outside the living organism is in vitro testing. Yesterday, I think you would have a detailed discussion on the in vitro testing. So in vivo testing comprises of one is skin prick test, intradermal test, patch test, and the challenge test. And in vitro testing comprises of total IgE, serum specific IgE, and now the latest addition is the component resolved diagnostics. So here we will be in a dilemma about what do we choose, whether we will choose in vivo testing or to choose in vitro testing. So there are certain points favoring in vitro testing, like it is widely available, little cooperation is required, and it can be done even when the patient is on drugs like antihistaminics or steroids. It can be done in any skin condition, unlike the in vivo testing in which eczema, we cannot do that, and lab standardization will be required. But in vivo testing, the single most important point we need to remember is this. So in vivo testing, it is based on the bound IgE. So it detects the real life biological situation inside the body. So it detects a clinically relevant hypersensitivity reaction, whereas your in vitro testing is going to detect only the free IgE levels. So in this aspect, this in vivo testing, skin prick testing scores over the in vitro testing for detection of IgE mediated sensitization. So that is why skin prick testing scores over the IgE testing or in vitro testing. Right. So there are different types of in vivo testing. Which one to use? For example, inhalant allergies and food allergy, which is most common presentation in children, the common test that is used is the skin prick test because it is very sensitive and standard commercial reagents are available for these two allergies. For venom allergy and drug hypersensitivity, intradermal test is used because they have the highest sensitivity for this kind of allergic reactions. For contact allergens like in contact dermatitis, the patch test will be used because that seems to be the more sensitive of all these tests. So based on the type of allergies, we can use which type of test that can be used. But for all practical purposes, most of our allergies in children belong to these two categories: inhalant allergies and food allergies, for which skin prick testing is going to be the modality of choice. Right. So now we will move on to the science of skin prick testing. So before moving on to this thing, allergic skin testing basics we should remember. Allergic skin testing basically it demonstrates the presence of specific IgE antibodies on the surface of sensitized mast cells. So by doing allergic testing, what we are going to demonstrate is only the sensitization. It does not indicate it is an allergy. So AST is basically an immunological test to detect the sensitization. You can be sensitized but cannot be allergic. That is why it is always in our course also it is frequently mentioned. Sensitization is an immunological term, whereas allergy is a clinical term. So you can be sensitized, but you need not be allergic. So that we should remember. And there are basically two types of allergic skin testing. One group is called the epicutaneous test, where the prick, puncture, and scratch tests are used, and the other one is the intradermal skin test. Of these three types, skin prick is the most commonly used. So if you see the differences between the skin prick and the intradermal test, the safety, reliability, all are very high, and clinical correlation also good in case of epicutaneous skin testing. Whereas in intradermal, the clinical correlation is low. Even though the sensitivity is very high, the clinical correlation is low, and the safety and technique is slightly complicated. So for all practical purposes, the allergic skin testing should be always start with the epicutaneous testing or the skin prick testing. If skin prick testing is negative and still you have a strong history of atopic sensitization, then your intradermal skin testing can be done. Right. What are the indications? What are the contraindications? Very simple. As commonest indication is respiratory allergies like your allergic rhinitis and asthma. And food allergies, particularly oral allergy syndrome. And drug latex venom allergies also can be used. And in skin conditions like acute urticaria and atopic dermatitis. What are the contraindications? Severe eczema or dermographism, or in conditions like uncontrolled asthma. And after recent anaphylaxis, up to 4 to 6 weeks, your skin test is not going to be useful because there is a temporary suppression of the mast cell response. So up to 4 to 6 weeks after the anaphylactic reaction, you are not supposed to do a skin prick testing. And patients who respond to negative control, they seem to have a higher sensitivity of the skin. So they are also not the good candidates for skin prick testing. And whenever the patient cooperation is poor, and what are the conditions where it is not recommended? So in conditions like chronic urticaria, food intolerance, irritant allergy like perfumes, incense sticks, testing for food additives and colors, and non-IgE mediated allergy. So all these conditions are basically non-IgE mediated reactions in which your skin prick testing is not going to be useful, because skin prick testing is basically done to diagnose IgE mediated sensitization, right? So how do you select the antigens? So number one is you need to have a good clinical history, detailed clinical history. You need to know what is the diagnosis, how severe is the diagnosis, it is a persistent problem or an intermittent problem. And second is the local aerobiology data, particularly if you are suspecting pollen allergy, what time of the year, what pollen is prevalent, only then you can choose the antigens for testing. And we need to know there are three classes of allergens. One is the inhalants, second is ingestants, third is the injectables. Inhalants are again divided into indoor and outdoor. What is indoor allergens? House dust mold, pollen and mold. What are the ingestants? Food allergens. And injectables like venom allergens. So when you are choosing an allergens, we need to know both these, what is the condition of the patient and what are the type of allergen we need to choose. For example, if we take the respiratory allergies like allergic rhinitis or asthma, if it is perennial, so throughout the year, that means it is an indoor allergen. So what category will you choose? It is an inhalant indoor allergen. What are the allergens that should be tested? All the indoor allergens like your house dust mite, cockroach, molds, pets like dog and cat. For example, if it is seasonal, so only its flare-ups are only in season. So then it means it is an outdoor allergen, inhalant outdoor allergen. So then the antigens that should be tested are tree, grass, and pollen. If there is a food allergy or drug allergy, so we need to find out what type of food or what drug are implicated, and we need to test for that particular food or drugs. And if it is a contact dermatitis, we need to check what are the contact allergens that is relevant, and we need to check for those particular allergens like plants, drugs, cosmetics, and nickel. So, since in our country, asthma and allergic rhinitis are more common, more than 90% of allergies, they can be detected with only 10 pertinent allergens. So, many centers employ a lot of allergic testing, like 50 to 100. Testing with a large number of allergens is not only going to be, is not useful, number one. Number two, it is not justifiable also. So, we need to choose 10 important allergens, we need to check only for those. No need to test for extensive testing for all the allergens. So before moving on to the test per se, what are the preliminary details that one should know? Number one, the device. Nowadays, the lancet is used. Now, the 25, 26 gauge needle is no longer used. And what is the place that should be for testing? Only either the forearm or the upper back. And what is the penetration angle? It should be 45 to 60 degrees. And depth should be between 0.5 to 1 mm. What is the amount of antigen deposited? It should be 0.3 ml. And what is the layer deposited? Just beneath the stratum corneum. And the interval between two allergens should be ideally at least 2 centimeters. And which area should be avoided? 5 centimeters from the wrist and 3 centimeters from the antecubital fossa. What are the vitals that should be monitored during the procedure are pulse, BP, and respiratory rate. So, we should always inquire the intake of interfering medications before doing allergic skin testing. Why? Because there are so much medications that can interfere with the results of allergic skin testing. So, we should take a thorough history about the medications before we start doing the skin prick testing. And what are the requirements that we need before doing a skin prick testing? We need to have standardized allergen extracts. And apart from that, positive negative controls, histamine and saline, sterile allergy lancets, sharps container for waste disposal for the contaminated lancets, marker pen to mark the sites of the allergen, measurement scale to measure the reaction, dry tissues to wipe off the excess antigen, and we also need to have these SPT recording forms. Right. So coming to the procedure per se, so we need to have the proper AST record sheet, and after introduction and detailed explanation about the procedure to the patient, we need to prepare the site using alcohol swab. So once the site is marked like 1, 2, 3, 4, 5, 6 for the allergens, so you should start with the negative control saline and end with the positive histamine control. And the placement of antigen should be done on marked sites. Once the antigens are marked, then we have to do the skin prick testing. While doing skin prick testing, it is very important we exert the same pressure for all the allergens. So if we apply differential pressure for each allergen, then the blood ooze can happen because of deeper pricks like what is shown in this picture. So we need to apply the same pressure on all the antigenic sites. So once the skin prick is done, then there are two methods. Either you can wipe the lancet with wet sponge in between the pricks, or you can use independent lancets for different pricks to avoid this antigenic overlap. And the result should be read after 15 minutes. So generally the maximum wheel diameters are measured and the mean value is noted, and that is the value of that particular reaction. So it needs to be documented your interpretation sheet. And after that, wipe dry the test site, and post test we need to give clear instructions to the patient, written interpretation of the report and explanation to the patient what is the allergen that is causing the allergic reaction, how to avoid, and what is the future treatment plan. So everything should be detailed explanation should be given to the patient, right? So coming to the next step, that is the interpretation. So interpretation, where the negative saline 0 to 3 mm is acceptable. For positive histamine control, it has to be 3 mm more than the negative saline control. And the positive skin test for allergens, it should be 3 mm or higher than the negative saline control. So what we should note is a negative saline control more than 3 mm that indicates dermographism, which means there is a baseline skin reactivity, which means the test is invalid. So a positive histamine control lesser than 3 mm means there is interference with some immunosuppression medication or antihistaminics. Again, this may be invalid. It is always better to express these skin prick test measurements in millimeters rather than using semi-quantity grading system like 1 plus, 2 plus, 3 plus. It was a system that was followed previously, but nowadays uniformly it is only the millimeter measurements that is followed and not this 1 plus and 2 plus. Right. What are the conditions that can cause false reactions in a skin prick testing? False positive reaction can happen following an irritant allergen, or it can be because of non-specific enhancement through axon. Particularly when the antigens are placed less than 2 centimeters apart, there can be non-specific enhancement causing false positive reaction. The studies have shown that recent RSV infection, respiratory syncytial virus infection, can cause false positive reaction. The exact mechanism I don't know, but literature suggests that there is a false positive reaction following recent viral infection. False negative reactions can also happen because of medications that I will be discussing a little later. And when the extracts with diminished potency, for example, outdated extract, or when it is not kept under storage conditions properly, then it can cause fall. That is why it is very important. We need to store the extracts in 2 to 8 degrees centigrade only. Post anaphylactic reactions, we already saw there will be a temporary suppression of the mast cell response. So it can cause false negative reactions up to 4 to 6 weeks. What are the other factors that can impact the results of the skin prick testing? The extremes of age, less than 1 year and more than 65 years. So in both these groups, they will have poor reactogenicity for the allergens. Sex-wise, there is no difference. Race-wise, it is observed that more wheals have been observed in black population. And with regards to circadian rhythm, the allergic activity generally peaks in the late evening. So that is why your skin prick testing positivity is more if done in the late evening times. And seasonal variation, particularly for pollen allergy, is observed, particularly in conditions like spring or late summer. The pollen allergy seems to be more than the other seasons. And skin conditions like eczema, we already seen that it adversely impacts the results of the skin prick testing. And potency of the antigen, the very important, the time, it should be 15 minutes from the time of injection, and the dilution used and the temperature at which it has been stored, everything plays a role in the results, in influencing the results of the skin prick testing. Right. What are the medications that can interfere with your skin prick testing? So commonest medication is your antihistaminics. If it is H1 antihistaminics, it should be 3 to 5 days. There should be avoidance period. If it is second generation antihistaminics, 4 days is enough, except for loratadine, which is a longer acting drug. For that, 10 days avoidance period is required. For oral bronchodilators and leukotriene antagonists, 24 hours is enough. For long-term oral steroids, you need to have avoidance period of at least 2 weeks. If the topical steroid has been used for in the site of skin prick testing, it has to be avoided for at least 3 weeks. So what we should remember is actually the other one. What medications do not interfere with the skin prick testing? Number one is inhaled nasal steroids. So number two is inhaled bronchodilator as well as inhaled corticosteroids, and short course oral steroids, particularly if it is lesser than 10 mg for given for lesser than 10 days, it does not impact the skin prick testing. And proton pump inhibitors, all these drugs are commonly used in children. You don't need to postpone your skin prick testing because these medications do not interfere with the results of the skin prick testing. So nowadays, newer devices have come for skin prick testing. The multi-test 2, which is an applicator, it has a 8 applicator prongs. So these prongs allow simultaneous testing for 8 different allergens. Basically, it is designed for speed and reproducibility. And the other one is a Comfort 10, which allows 10 extracts to be tested at the same time. And again, all these devices come with a depth guard so that you cannot exceed the depth, you cannot go very deep. It has a depth guard for uniform penetration. So these are some latest devices that has come. Predominantly, it has been used in the Western world. In India, it is yet to come. Maybe in future, we'll be having all these devices. So one more modification of the skin prick testing is the prick to prick test. Particularly, it is very reliable for fresh fruits and vegetables, but particularly for those agents in which we do not have commercially available extracts. In these situations, it is a very safe, very easy technique. First, the lancet is introduced into the fresh fruit, and then it is introduced into the patient's skin with the same lancet. And it's a method of reading is also like the same. The results are read at 20 minutes, and anything more than 3 mm is considered as positive. So few practical points regarding to skin prick testing. So the correlation of allergic skin testing with immunocap is as high as 80%. For food allergies, the higher the size of the wheal, the more severe is the food allergy. Similarly, for airway allergies, respiratory allergies also, if for example, if house dust mite, higher the size of the wheal for house dust mite, more severe is the asthma. So the size of the wheal indirectly gives an evidence that the severity of the allergic response is also more. And with regards to allergen immunotherapy, it has been shown that there is a decline in skin prick testing reaction after 3 years of treatment. So this particular point is very important. When reporting the results of allergic skin testing, the term allergic has to be avoided. Always use the term sensitized. Why? Because so we are doing only an immunological testing. It is not a clinical test. So and you always have to report on the positive and the negative controls also. What we should remember is AST can be positive in asymptomatic patients also. So always we should interpret as sensitization only. The term allergic has to be avoided when you are interpreting the skin prick test reports. Right. So we'll come to the case scenarios. So this is a 16-year-old adolescent presents with rhinorrhea, sneezing, and itching. The symptoms are present on a daily basis for more than 2 years, and no seasonal variation is observed. There is a strong family history of allergy for both the parents, and they have a pet dog at home. Now, what is the diagnosis? So symptoms are present on a daily basis for more than 2 years. So more than 4 weeks, more than 4 times a week for more than 4 weeks, which means it is persistent. Symptoms are troublesome, affecting the daily life, which means it is persistent. So it is a persistent allergic rhinitis, moderate to severe perennial type. Right. What antigen to be tested? So this is an indoor allergen. So because it is a perennial type, we need to check for the indoor inhalant allergens like house dust mite, cockroach, mold, and pet dander. And what treatment will be suggested? Allergen avoidance, that like house dust mite, pet control, and antihistaminics, intranasal steroids. And then we have to plan immunotherapy once the disease process is under control. Right. So case 2, this 7 months old infant had recovered from the episode of anaphylaxis 1 week back. He is now brought for further evaluation. So both parents are asthmatics and baby has been recently started on cow's milk and weaning food. On examination, baby had red crusty patches over the cheeks and the limbs. So what is the diagnosis? It is straightforward. The baby has an atopic dermatitis and has recently suffered an anaphylaxis, possibly because of cow's milk protein allergy. Right. How will you investigate? Here, we should be very careful because skin prick testing, we have already seen it is not recommended for anybody who has just recently had an attack of anaphylaxis, because it is not recommended for anybody who has suffered anaphylaxis in the last 4 to 6 weeks. So we cannot use skin prick testing here. We should be using the immunocap for specific IgE, both towards the aeroallergens and the food, including milk, soy, and wheat. So how will you treat this child? Emollients and topical steroids for atopic dermatitis and food allergen avoidance based on the immunocap results. Right. So what are the key messages? Skin prick testing is a most rapid, safe, simple, cost-effective, and clinically relevant method for detecting IgE-mediated allergen sensitization. And detecting the allergen by skin prick testing is necessary not only to suggest avoidance measures, but also to plan immunotherapy. The results of the skin prick testing should always be interpreted cautiously, taking into consideration number one, patient's history. So whether it is clinically correlating with the history. Number two, whether the patient is on any medications. We saw that medications can adversely affect the results of the skin prick testing. And the other factors, like we saw the age group and other things, other factors affecting the results of the skin prick. So all these things, after taking into account, then only we should interpret the results of skin prick testing. Right. So this is the model of the skin prick testing form that we use in our center. So very important is, apart from the patient details, the allergy history and the medications that the patient is already on, and what is the period of avoidance, everything should be documented here. The start time, end time should be documented here, and the measurements and results should be documented here. Very important is the validity and the interpretation. So the test is valid with positive histamine and negative saline controls, and interpretation, the subject is sensitized towards sensitized for the following allergens. So here we need to use the word only sensitization, and the word allergic should not be used in the interpretation form. And this is the handout that we give to our patients, like for various allergens, how to prevent and what are the preventive measures that can be taken for allergen avoidance. This is the form that we give for our patients. So thank you all for patient listening.
Thank you, sir, for that very well structured presentation and a very insightful talk on this very much important topic, actually, for all of us. So it was the messages were really clear that the clinically relevant allergens are the most important ones, and not like multiple allergens which are not relevant. And the word sensitized, as you said, should be used and not allergic, because once it is positive, we have to go back again, recheck the history, and see whether it is correlating. And then if the symptoms correlate, probably like for house dust mite, if there is morning symptoms and all, then call it as actually causing the allergy for that patient. So it was an excellent session. We really enjoyed it. So just one question, sir. If the multiple side, the prick one which you said. So recently I'd seen that one of the companies was showing it. So they were saying that the wells have to be filled in. Uh, first, and then that is one thing which is little difficult probably, but maybe useful in kids when we don't want to show them multiple.
Yeah. So recently I saw this multiple test
Yeah,
result at the PED Allercon conference.
correct,
On
correct,
the
sir.
testing, they showed this actually, but since we are not, it is not regularly available, so we are yet to use
Correct.
the device.
Yeah, even personally, I have not tried it as yet. Yes. And this one, this one difference you have found between the 1 mm and the 3 mm, sir? Any 1 mm lancets or something which some of the companies were providing. So, any experience?
I don't find
Yeah,
any difference. I have used both one
yeah,
EMM.
yeah.
Clinically, it's not much different. The reaction size, wheel size, everything remains the same only.
Correct, correct, sir. Okay. Thank you so much, sir. There is no question in the chat box as of now. In
Dr.
case if we
Sanchana,
have later.
Dr.
Yes, sir.
Sanchana, can I
Yes, sir.
make one comment here?
Yes,
So
sir.
I have actually got some practical experience for this multiple allergens which are tested simultaneously. So when I was in US, so in US there is a very common practice, especially for the pediatric age group. So where what nurses usually do, because children usually are not that cooperative with many times prick. Then at that time, with this 6 or 8 allergens, probably 8 allergens, they are taking in the well. So I have seen that, and then they are dipping this means like the entire app inside the allergen wells, and then in one time bow, they are just, you can say, like sticking to the child and then removing it, so that they need not to prick again and again. And that's why
Yes.
they get, you can say, like a better compliance with the children. But you rightly mentioned that there is more allergen wastage, and I completely agree with
Yeah.
you. So it all depends upon the scenario and all those things. Both things have their own risk and benefit. The other thing is that in this multiple allergen prick, basically you do not require any particular technique. You have to just go and you
Press.
can say like press it. Whereas in the skin prick test, especially with the 3 mm, you actually require the specific technique. With 1 mm, you can still go directly down. So here you do not require any particular technique. But yes, from the allergen wastage point of view, I completely agree with you that yes, there is a risk for that.
Yes, sir. Maybe once we start using and become more
Yes.
comfortable, it will be
Yes, and
useful.
even the needles here are actually, you can say, like at least 2.5 centimeter to 3 centimeter apart, so that you need
Correct.
not to worry about that okay, the two allergens or the two pricks will meet each other or something like that. So rest of the other things are good. It is only probably the allergen wastage which is probably one thing which is a little setback in this. Otherwise it is a beautiful you can say like technique of the skin prick testing.
Yes. The initial preparation is little time consuming,
Yes,
only that
yes,
otherwise it is easy to
yes.
use. Correct, sir.
Yeah.
Thank you, sir, for that comments. And
Thank you.
shall we move on to the next session then? So, next session is a very important diagnostic tool in allergy, especially for allergists as well as dermatologists. So it's the patch test, and the topic is where and how. Patch test, where and how. And we have to speak on this session. We have our very own Dr. Deepti Pujari, madam, who is an expert, especially in this topic of contact dermatitis. She is an allergy consultant and pediatrician at Dinanath Mangeshkar Hospital, Pune, and she's the head of the department of the allergy unit there. And she is a YAKI certified allergist, and she's a faculty at various allergy courses across India. She's a national trainer for modules such as QTIS, REAP, and ATM. Madam is an excellent orator, and we have all heard her in different national conferences and different platforms, and she's always been really good. And we welcome you, madam. It's a privilege to have you today to speak on this very important topic on patch test. Welcome, ma'am.
Thank you, Dr. Sanchana, for that wonderful introduction. Can I start sharing?
Yes, yes, ma'am.
So, I'm really thankful to Dr. Neeraj Gupta for having me here and Dr. Sanchana for that wonderful introduction.
We can see your
Just
slide.
yeah,
Yes.
let me make it full screen. Can you see it full screen now?
Yes, yes, ma'am. It's good.
Okay. So today, my topic is about patch tests. So moving on from IgE, we are slightly shifting. These are late reactions, and mostly it is T cell mediated. We'll see what it is. Okay. So contact dermatitis, it is characterized by maculopapular rash, which could be exfoliated. It occurs when skin comes in contact with an irritant or a sensitizing substance. Okay, so it need not be allergic all the time. It could be just irritant, like Dr. Ilaiyaraaja said that there are some irritants like perfumes and strong smells and the exhaust. Same way here also there are irritants. So because there are a lot of cosmetic use nowadays, artificial products are loads in the market. This incidence of contact dermatitis is also increasing. Females are mostly more involved because they are using more cosmetics. It is type 4 hypersensitivity. So now we are moving from IgE, that is acute type 1, to contact dermatitis, which is delayed type 4 hypersensitivity. So why we do patch test, when, where, how, we'll see in the next few slides. I have 15-20 minutes now. Okay. So coming to the irritant contact dermatitis, as I was saying, it is not allergic here. It is repeated exposure to concentrated irritant. And can you see the irritants are our soaps, detergents, acid alkalis, even our own body fluids, saliva, urine, feces, and sweat. Your mango, citrus fruit, pulp, shrimps, anything that is repeatedly applied in higher concentration can give rise to irritant contact dermatitis, simple thing like saliva itself. How? We'll see. So these are some of the examples. If you can see, this on the right side, I have shown a child with perioral rash. Now, this child would get very anxious all the time before the exams and start licking the lips. So, because of repeated exposure to saliva, which is not at all allergic, saliva is not at all irritant, but repeated exposure has caused this. Same way, can you see this child was using these shin guards in summer, which gave rise to irritant contact dermatitis. Now, my topic is patch test. Here I'm saying because of the sweat and lot of friction because of these shin guards, it's called irritant contact dermatitis because I have not done patch test on this child. Had I done patch test and maybe shown that this child is allergic to this blue color or some material in the shin guard, some epoxy resin, some mercaptobenzoyl peroxide, something, then from irritant contact dermatitis my diagnosis would have changed to allergic contact dermatitis. Here I'm thinking simple sweat and friction has caused this, so I'm calling it as irritant contact dermatitis. Again, like Dr. Ilaiyaraaja said, in skin prick test, history is so important because here you can pass it on as anything, eczema or anything. So every time this would happen in summer times when summer holidays, he would play with the shin guards. So the diagnosis of irritant contact dermatitis or allergic contact dermatitis. And we are all very aware, urine and feces, if left for a long time. Again, urine and feces are not irritants, they are not allergens. But if left for a long time under the nappy, they release ammonia, cause irritation, and cause irritant contact dermatitis. That's why the folds are spared where urine doesn't come in contact. Okay. So again, repeated hand washing giving rise to lot of irritation in the skin. Again, I've done patch test, so I'm calling it as irritant contact dermatitis. I don't know. Maybe after patch test, one of the ingredients in the hand wash could be positive, and then I might change my diagnosis to allergic contact dermatitis. Here, because of repeated hand wash, I didn't do any test. I'm just calling it as irritant contact dermatitis, and I'll tell the patient to avoid using repeated hand wash. I hope it is clear. And coming to allergic contact dermatitis, as I said, it is type 4 hypersensitivity. And it again, as in in your IG mediated, there is sensitization phase and elicitation phase on re-exposure to the same antigen, and it causes inflammatory mediators to release. It doesn't happen immediately, can take 8 to 12 hours. And once it happens, it can persist for 3 to 4 weeks. Generally, 8 to 12 hours I have written. Sometimes you can see late reactions up to 2, 4, 6, 7 days also. And they tend to persist, and that is the typicality of type 4 hypersensitivity. Okay, now coming to the cases, as I go on, we'll take one by one case and we'll see how allergic contact dermatitis it presents. This 14-month-old child present with a rash on the ankle. This was on both the ankle, only on the ankle since last 2 months. And he was being treated as atopic dermatitis. Now, my point is why atopic dermatitis at the age of 1 year should suddenly come only on the ankles? It's absolutely irrelevant. That's why history is so important because we all know atopic dermatitis has age-wise distribution. It should have started from the face, chest, if at all antecubital fossa, popliteal fossa. No business suddenly appearing at the age of 1 year only on the ankles. So on taking proper history, came to know on his first birthday, he started wearing these anklets, and that's why only on both the ankles he was having this rash. So what it could be? Most likely, again, you have to do patch test here. If you're not sure, and we all know artificial jewelry has a lot of nickel, and many patients or people are sensitive to nickel. So yes, this child turned out to be nickel positive, and it is present in so many things: your earrings, anklets, watches, watch straps, buckles, necklaces, orthodontic devices, cooking utensils, razor syrups, and you name it. Even though over-the-counter multivitamins contain high level of nickels, your herbal teas, herbal remedies, high level of nickel. These are some of the foods I have mentioned here. Your nuts, whole grain, flours, oats, soybeans, shellfish. Why I have mentioned? Because if a child is positive and having severe sensitization to nickel, you would want them to avoid these foods because there is a condition called hematogenous spread of contact dermatitis. So you might want them to take less amount of these foods. Okay. Remember, some medical devices also have high nickel content, and nickel allergies are very common in our country. Okay. Now let's see another case. This 28-year-old female, can you see this inflamed face, all red face, itching and burning all over the face, and it started suddenly 2 months back. Again, and it was not present in any other part of the body. That was very specific. So, on again, she wouldn't come with a history, but on repeated asking, she said that she has started using this pineapple and papaya face scrub. Now, she was not ready to agree that she could be allergic to this because, according to her, it's very natural. Natural pineapple, natural papaya, and she says she eats it all the time, so she's not allergic to it. But when you see the label, you see there are n number of ingredients. So here is the place where you don't know what she's allergic to. Here you will do patch test. Patch test for what? I'll tell you. And she turned out to be positive for lanolin when we did patch test for her. Again, lanolin or bull alcohol is present in n number of products. Almost all the cosmetics. Lanolin is used as a base. I've still yet to see any cosmetic that doesn't have this. So all your foundations, eyeliners, shadows, lip balms, lipsticks, hairsprays, hair removers, soap, shampoos, balms, creams, everything almost has lanolin. She was very lucky that she didn't have any reaction till now, but could be that face scrub due to scrubbing, it caused a lot of penetration and she showed the reaction. Again, another this 26-year-old came with severe burning, itching, redness over her scalp and neck. This is her neck, this is scalp, no relief with antihistamines. Again, she kept saying she hadn't used any soap, shampoos, foundation, nothing came. But there was a positive history that she has used hair dye 3 days back. So, as I said, if you're lucky, you'll get reaction on applying hair dye. But because it is T cell mediated, there are delayed reactions. You have to take history very properly. History is a must. So, on repeated asking, we came to know that she had used hair dyes 3 days back. So, again, hair dye. So, this is the back of the hair dye. It has again n number of products. A patient can react to anything. We did patch test for her, and she was positive for paraphenylene diamine. It is a black rubber mix. It is used in shoes, tires, sporting equipments, headphones, goggles, etc. And it is very commonly nowadays used in hair dyes, tattoos, and hennas. And because females are using this more often nowadays, these allergies are coming in a big way. Okay. So sometimes you could make this. I've put this slide because Peru balsam or balsam of Peru, again, it is a fragrant material used in so many products. Whichever product, even your moisturizers, your perfumes, your hair dyes, or your, foundations, anything that smells good, your powders, shampoos, that smells good has balsam of Peru. Again, one of a very common allergen amongst the contact dermatitis allergens. One more case. This 5-year-old child started developing this rash over the foot and all the toes of his feet, both the feet, since last 1 month as he started playing outdoors. Parents thought it was the dusty atmosphere that is causing a lot of irritation. Then they thought it could be shoe bite. They kept cleaning his legs, but the rash just kept increasing. Now, my point is again, history gives you a lot of information. What suddenly happened? The child must be, he's 5 years old, the child must be playing outside many times in his last 5 years. There is dust all over India, and why dust should cause such severe reaction on the feet? They were cleaning his leg again and again. So my first suspect is, what was it, the soap or the detergent or whatever they are using in the cleansing as the cleansing material? Was it causing the rash? But again, as I said, history play comes in a big way. On asking deeper, they said he has started using new shoe. Could it be shoe bite? Now, again, why shoe bite? Shoe bite doesn't come like this. It has no business to affect all the toes and the sole wherever the shoe is coming in contact. So this was again contact dermatitis to the one of the contents in the shoe. Again, you have to do patch test. On doing patch test, he was positive for epoxy resin. Again, epoxy resin is a material that is used to harden or cure many substances. Let's not go into detail as we are running short of time. So it is used in paints, casting, resins, anything to thicken it or to coagulate any material. It is used because it can be molded easily. Okay, it has a slow setting and extremely heat and chemical resistant. So it is used in n number. Even your glass frames has it, handbags have, your belts and shoes. They are commonly epoxy resin is one of the ingredients. So now, as I was telling you, how do we come to the conclusion? How do we know it is epoxy resin? How do we know it is methylene diphenylamine? Or how do we know it is nickel? How do we know it is lanolin? It is very difficult to know because you cannot predict of so many ingredients that are there what the child could be reacting to. So there are lots of series here. Can you see there are, so we don't know what the child could be reacting to. So ideally we should be doing the whole, test the child with all the ingredients. Can you see these are so many, again, your footwear series. So this is your cosmetic series or your footwear series or Indian standard series. If you're not sure, you have to do all. You cannot just do nickel. You cannot just. I didn't know that the child was allergic to epoxy resin. When we do all, the child turned out to be positive for epoxy resin. When we do all, the child turned out to be positive for, the female was positive for lanolin. It's very difficult to predict. So you have to do, either you do your Indian standard series or your footwear series or cosmetic series, whatever you are happy with, whatever you are keeping in your fridge, or you can do all. So then how is it done? So now you know how you will think, what you will think when you're doing patch test. And these are some of the examples. Depending upon which area is affected, you get that type of allergic contact dermatitis. So, like Dr. Elena just said, you get skin prick test. In the vials, you have allergens. Here you have tubes that are filled with the allergens. And here the negative control is Vaseline, and rest all are the allergens. These allergens are placed in the wells that come, and Vaseline is always put as a negative control, and depending upon which series you want to use, you'll fill the wells and you'll stick on the back of the patient. So you'll fill all these wells with the allergens and you'll stick. You label the wells on the sticky tape, plus you label the patient's back also, because at the end of applying 30 allergens, you'll not remember which was there. So labeling is very important. Correct labeling. The one label, first allergen from this should go in the first well, which you should label as one, and the skin should also be labeled as one. Likewise, you'll put all the wells with the allergens that you want to test, and you'll secure the back properly with again one more tape so that these wells don't fall down. Because remember, they have to be kept without washing for at least 48 hours. After 48 hours, you'll remove these stickers, you'll remove the wells, and you'll take the reading. Till 48 hours, you have to instruct the patient not to take bath. The patient shouldn't run. The patient shouldn't sweat. The patient should sleep properly. There should, wear loose clothes, wear loose cotton clothes. There shouldn't be excessive friction from outside. No sweating, no bath. After 48 hours, when you remove, you take the reading. This reading is not the final. You have to call the patient again after 72 hours, again after 96 hours, and now Yaki is saying the final reading should only be given after 7 days, because as I said, it is T cell mediated, it's delayed hypersensitivity, you get delayed reactions. So can you see here on the right side, we can see one well has lot of papulonodular rash and lot of redness compared to the other wells. Same thing, it can be appreciated here, very well seen on this right side picture. You can see papulonodular reddish discoloration in one of the wells. So this is how you take, and the final reading, you have to wait at least till 4 days, if not 7 days, and that is the time you will give final reading. So once you open the back, you don't reapply the wells, you leave it like this, but still you tell the patient not to take bath for another 3 days. You call them again after 2 days and again after 2 days, and then you give the final reading. So based on redness, induration, and blistering, you give negative or mild, positive, moderate, severe, whether it was just an erythema, there were vesicles, or there was bullous reaction. So you give 1 plus, 2 plus, 3 plus. Okay. Or if it was nothing, then you have to give negative. So some do's and don'ts, like your skin prick test, here also oral steroids should be stopped at least 3 weeks before testing, and local steroids at least for 1 week. Immunosuppressive drugs need to be stopped depending upon which immunosuppressive drug you are testing. Antihistamines do not have any role here because it is type 4 cell mediated immunity, and they don't interfere with the test. Patch testing should be deferred in extensive active dermatitis, because if the back is totally inflamed, you will get false positive results. And again, there are some pitfalls here. You can get false positive if it is irritant contact dermatitis to adhesive tape. Now, can you see here very clearly in the picture, the well is empty, the well has not reacted, but the tape where it was put, the tape has reacted, the patient was allergic to the tape. It could be just irritant contact dermatitis. You can get false positive reactions due to pressure effect. You have pressed a lot, so pressure can cause a lot of irritation and give false positive reaction. Excessive heat, can give false positive reaction. It can facilitate the penetration of allergen and can give you false positive reaction. So some of these things you should always remember before giving any test results. Same way, you can have false negative reactions also if the concentration of allergen applied was not sufficient. While you are applying, you put the allergens on the wells, and by the time you are applying on the patient's back, the allergens tend to slip down. There are some liquid allergens, they fall down. Formaldehyde, like it is liquid, it tends to slip. So the well could might just be empty when you put it on the back. So it's very important, sufficient quantity. The allergens are not as same as skin prick test. The allergens have their half-lives. They have to kept it 4 to 8 degrees inside the fridge. They should have good potency. They should have, you should always check the expiry date before applying. And if you selected the wrong, instead of cosmetic, you chose your footwear series and your allergen was not in that series, then you might miss the allergen. So it's best you go with Indian standard series or do extensive test when the history is not very clear or you have not chosen the allergy, or sometimes you get false negative when you didn't wait very few times, especially epoxy resins and all, they have very late reactions. So ideally you should wait for 7 days before you can say okay, the test is negative. So these are some of the reasons where you get false negative reaction. This is, a simple test when you don't want to do your patch test. You remember in your skin prick test, you don't do your skin prick test near the antecubital fossa because it is very sensitive. At least 4 centimeters you don't do. Because it is sensitive, you do your repeat application test for contact dermatitis near the antecubital fossa. You just apply some amount of the allergen there, leave it for at least an hour. Twice a day, you do it repeatedly for 7 days, and even after 7 days on repeated application for at least an hour, twice a day, you don't see any reaction. It is unlikely that the patient is suffering from that allergen, and you can rule out that product as a product for contact dermatitis. And now, once you have, just for completion's sake, 2 more slides. Once you have detected that something is positive, in all allergies, avoidance is the best everywhere, whether it's IG mediated or delayed or non IG mediated. If you have detected an allergen, it is best to avoid it. So, avoidance, avoidance, avoidance. Cold compresses work wonders because it's very irritating and itching. You put cold compresses and gives quick relief, and all your emollients, your calamines, cold water, saline, they really help a lot. Then, of course, topical corticosteroids work very well. You can give them for 7 to 10 days, short course, and once you start avoiding, the rash disappears quickly. Topical calcineurin inhibitors can be applied if there is very extensive on the face. You don't want to use your topical steroids, then your tacrolimus and pimecrolimus, depending upon the age, you can use it 0.03 or zero point 0.1, less than 15, more than 15 years age. Systemic corticosteroids you'll only use if more than 20% body surface area is involved, and that too in a very low dose, 0.5 to 1 milligram per kg per day for not more than 7 to 10 days. I repeat, mostly topical corticosteroids do the work, but if more than 20% body surface area is involved, you can go ahead with your systemic corticosteroids. And of course, supportive treatment you will give. If it is hand dermatitis, you ask them to avoid hand washing. You can give them heavy duty gloves if they can't avoid detergents and soaps. Tell them to avoid the makeup products. Try and use fragrance free, color free, dry free products. They are less allergenic. In foot dermatitis, it's very useful. You ask them to wear cotton clothes or ask them to wear canvas shoes, because in our country, shoes don't have labeling. You don't know what ingredients were used. So canvas shoes or cotton socks are very good. Metal fasteners to be avoided if someone is allergic to nickel, so on and so forth. Try and avoid all dyes and artificial products. This would be if the patient is allergic and needs to avoid the product for lifelong. Thanks.
Thank you, ma'am, for that very informative session with very practical points and case scenarios which we commonly encounter in our practice. It was an excellent session. And uh, just one query would be since I practice in a area which is where the monsoons are very very significantly more actually. This clinical scenario which I had come across where the footwear allergy. So when I asked them about wearing other shoes, they were like, because the rubber shoe what they wear normally for rainy wear, they cannot avoid it at all because that is the common thing. So in that case, if they really are allergic, even canvas probably may not work in that situation. So any practical experience on that, ma'am? Like what can we do?
Dr. Sanchana, very good question. All the time, if they are wearing shoes that need not be the allergena, beware. you won't believe the in rainy season, if they are going out in the fields, the pesticides used could also have lot of, the sprays that are used in the fields, they have lot of allergens. Patient could be having contact dermatitis to one of the products that is sprayed in the fields also. So need not point to the shoes all the time. But now if a patient, has to wear those gum boots or those shoes going in the fields, what and socks won't work because the feet might get
Yeah,
wet.
yeah,
Simple, best, sasta, sundar, tikau tarika, wear a polythene. Literally wear a simple transparent polythene on the shoes, and then the patient can wear those gum boots if he's really really allergic to them. But beware, it's not always shoes. There could be anything that is otherwise
yeah.
coming in the contact. You have to rule out that also. So here the patch test would be recommended.
Yes. And then how much time is it enough for that patch test, that content to be in contact? Because when I saw the patient in 48 hours, the tube had already kind of slipped. So whether we can be sure that it would have delivered the
No, you'll have to repeat the test 48 hours. It has to be 48 hours. That is the standard
exact.
guidelines. So if you think that the ingredient had slipped, you'll have to repeat the test.
So how much ever we secure, I think with some patients who are very sweaty and all.
Yeah.
Yeah,
So again, it's easier said than done. Patch test is not
it's good.
simple, and the
Simple.
interpretation sometimes becomes very difficult. But you have to give strict instructions not to take bath, not to run, not to sweat, not to go out in the sunlight, wear loose clothes, and tie it twice or thrice. Sometimes, for children, mothers use a bandage and they tie all over the chest, all the way
Okay.
like this. Yes, because you
Oh,
need to secure. Yeah, otherwise it tends to slip.
correct, ma'am. Yeah. And a difficult task in kids, definitely.
Yes,
Yes.
yes.
Thank you, ma'am. There are no questions in
That's
the
it.
chat box as of now. If we have some, we will come back to you again if
Dr.
you're
Sinchana, can I
free.
can I ask
Thank you.
two things here? So,
Yes.
one, Dr. Stipti, excellent presentation once again. I
Thank
have heard you so many times for the patch testing, and each and every time I learn something new. So, two things. One, once again, reiteration just to my understanding. So, the patches need to be applied only for 48 hours, and after 48 hours, then we will remove them, but we need to observe them up till 7 days.
Yes.
Correct.
You don't have to reapply the patches again. Just
Correct.
remove, but you have to call them again after 2 days and again after 2 days because it's a delayed hypersensitivity. Not every patient will react after 48 hours.
Sure, sure. One question means like this is just only 3 days back. One lady came to me somewhere around 59 year old, and she came to me with a history that she has experienced 3 episodes of anaphylaxis in almost last 6 months. Out of which, what has been managed, you can say like with antihistaminic, with steroid in the emergency. Another, she required epinephrine, so that means it was documented anaphylaxis. She required epinephrine. And third one also, it was managed by, you can say like with this antihistaminic alone. Now, on taking a deep history, there was no risk factor, no use of beta blocker, no other drug medication, no nothing like that, no previous history of asthma or rhinitis, nothing, whatever we can think about. There is no change in the environment, there is no change in the food, there is nothing change, no triggering factor. Then she is very categorical. Then on the day of anaphylaxis, whenever she developed this, so prior to that, somewhere around half an hour back, 1 hour back, she applied dye in the hairs. Now, uh, but she also says that there are some other days on which she applies the same dye, but she doesn't get any reaction. But these 3 episodes of anaphylaxis, she distinctly remembered that all 3 times she has applied the dye, same brand. So now, what is the interference for all these things? Means like what exactly is happening now?
First of all, I'll do patch test for the dye. 100%. So things become very clear. Patch test is safe, it won't cause anaphylaxis. Okay. So patch test for the dye is the best answer to this. Now, why it is happening sometimes and not the other times? It's exactly what we get for your non-steroidal anti-inflammatory groups. If you have viral infection, if you're toxic, fever, and you use your NSAIDs, you might show severe anaphylaxis. Other times you are taking your NSAIDs, you might know. So if she used lot of dye, maybe same brand, the quantity was more, she left it for longer duration. Sometimes it is asked to remove after 15 minutes. She left it for an hour. She was busy somewhere. There was more contact. She scratched it. So more penetration. There was some sore in her scalp, some crack in her scalp, which increased the penetration. She was herself not well. She was having viral fever. With it, she had taken some NSAIDs, which are known to cause. So all these confounding factors need to be taken into consideration, not only with your delayed hypersensitivity reaction, your severe IG mediated reactions also. So, having said that, delayed contact dermatitis very rarely presents with anaphylaxis. You get severe reaction, you get anaphylaxis in hematogenous spread of contact allergens. It is known. So that's why I'm saying, did she have some cut in her scalp? Did she scratch it? Did she leave it for too long a time? Was she having viral underlying infection? Did she take NSAIDs with it? All this history needs to be taken. Then you can think of hair dye doing it. You might want to definitely do patch test in this patient and rule out, and you can do the patch test with her dye itself. You'll do your cosmetic series, plus you'll use her dye to do patch test, and then you can come to a conclusion.
So what I understand, what you are saying is that suppose if the same allergen, which is supposed to, if it is supposed to react through type 4 mechanism, it is probably reacting through type 1 mechanism also, if it
Yeah,
is directly penetrating in the blood or
that
in
is
the
known.
system.
Hematogenous
Correct.
spread is known. Yeah.
Correct, ma'am. Now, my question to you is here in the same context. My question to you is that let's do the patch test, and suppose if the patch test is negative or positive, it is only telling us about the status of type 4 hypersensitivity. Even if it is positive, it is not telling us that it is also creating type 1 hypersensitivity responsible for anaphylaxis. If it is negative, then also it is not telling us and ruling out about type 1 hypersensitivity. So, in this particular case, even patch test done, whether positive or negative, how we can attribute that to the episodes of anaphylaxis.
Okay. So very clear answer, no confusion in this. If a patient has had anaphylaxis thrice and all the three times she had used that dye, 100% without doubt, I'll tell her to avoid it. If her patch test has come negative, because patch test will tell you about contact dermatitis. If you're lucky, she'll have positive reaction. But if you're thinking of hematogenous route, and if suppose are with hard luck, because we don't have our confounding factors during that time. As I said, we don't do patch test on a cracked skin. We don't do patch test when the patient is having fever. When viral infection, we don't do patch test when patient has taken non-steroidal anti-inflammatory. So we don't have those confounding factors. So we might get false negative patch test. But in practical life, what you'll do, you'll definitely tell her to avoid that period, and that's the end. You'll ask her to avoid all possible hair dyes. Tell her to
Sure,
use
sure.
simple
Thank you.
mehendi.
Thank you, ma'am. Thank you.
Yeah.
I think, thank you.
Thank you, ma'am. Thank you, Neeraj sir. Moving on to the next session. We've all read it in textbooks, and we all attribute it as a research tool in allergy. So that is the basophil activation test, translating bench to bedside. As we all know, just like eosinophils, even basophils are the culprits in allergy, and this test is a good in vitro test to provide valuable insights in the diagnosis of IG mediated allergy. And to speak on this, we have Dr. Kunal Chandwar, who is a practicing clinical immunologist and rheumatologist in SG, PGIMS, and KGMU Institute, Lucknow. He has also trained in London and Milan, and he's trained in allergy through the IACI and Quadri. He has many awards and research papers to his credit. He's a very good orator, and his special interest is in Sjogren syndrome, SLE, myositis, and allergy and immunology. We welcome you, Dr. Kunal, to this session, and we are extremely happy to have you here and privileged to listen to you. So, over to you.
Thank you so much, ma'am. So a very good evening and thank you, Neeraj sir, for the kind invitation. Allergists are usually considered as the more boring set of doctors. And is the screen visible?
Yes, it is.
Yeah, okay. So I'll be talking about basophil activation tests, and I'll try to simplify these tests as far as possible. There'll be a small insight into the newer section of mast cell activation tests at the end of the talk. And just to start, so we have had discussions regarding specific IGs, component resolved diagnostics, and skin prick tests. And the problem is, you have a patient who has a convincing history to give. He says that he is sensitized or has classical clinical features to suggest allergy to something, but your specific IG is negative, your skin prick test is negative, and what to do now? Now, the patient or the patient is positive on both the skin prick test and the specific IG, but they don't have any clinical features to suggest that the allergy is there. The patient has multiple sensitization, or the patient has a history of anaphylaxis and nothing has come positive. So, in all of these situations, there is a possible role of a basophil activation test. So you have all of these queries. You still, based on your skin prick test or specific IGs, can only say that the patient has sensitization, that there are antibodies in this patient's blood or in his skin. Whether they are actually leading to any classical clinical symptom, you're not that sure. So, how do you become sure? You do tests that will tell you whether the gun can actually fire when you encounter an allergen. And these can be done by direct challenge tests, whether you have the oral food challenge test or the nasal provocation test, and see that this is happening inside the cells or not. And the same thing can be told by the basophil activation tests also. It is finally the patient's own basophils that are exposed to an allergen, and through that you can quite conclusively tell whether the patient has clinical allergy or not. So, what are basophil activation tests? They are classically called as a functional assay. That is, it is an ex vivo test in which we take the patient's own cell outside their body, expose them to an allergen, and see whether this is activated. The basophil degranulates and activates on exposure to the allergen or not. And how do we test this? We test this through a flow cytometer based test. We'll come to the details of the test as we go along. And what are the principles? So the principles are that the basophils and mast cells are coated with high affinity IgE receptors, the Fc epsilon receptors. And in an allergic patient, these receptors are armed with those specific allergen specific IgEs. And when you expose the allergens, the IgE will bind to the allergen and there will be an antigen antibody complex that is bound to the basophils again, and this cross-linking will trigger an activation or a degranulation and other mediators that can cause symptoms, and basophil activation test measures this exact event. So what are the markers that we usually measure in a basophil activation test? So there are certain markers that are not as well expressed in resting basophils and only present when they are activated. So there are two specific markers. We measure the CD63, and this is called as the degranulation marker. So that this is normally hidden inside the basophils, and when it degranulates, it comes outside and gets expressed on the surface. So in normal non-activated basophils, you won't see any CD63. In the ones that are degranulating, only then you will see CD63 being expressed. Same way, CD203C is an activation marker. So if the patient's basophils are not activated in resting stage, these markers will not be seen. Whereas if this is activated basophil, you will see an increased expression of CD203C. So, how do you do it? You identify the basophils first through a flow cytometry technique, and you also, in the same time, keep these basophil cells and add a positive control, a negative control, and the allergens that you want to test. If the allergen is activating the basophils will now have expression of the activated basophils, and this you can assess through the flow cytometry techniques. So you will find basophils with increased expression of CD63 or CD203 on your flow cytometry report. So what are the usual steps, how it is done? So you collect a sample, classically a fresh sample. The best time to do is it within 4 hours. You can stretch it to a maximum of 24 hours after taking the sample. You stimulate the bloods, aliquots of the blood with allergens and controls. You give positive control, negative control, and the allergen. And then you stain the cells with fluorescent antibodies for basophil identification and basophil activation. And then you analyze the flow cytometry based on what percentages are activated and what percentages are degranulating. The critical pre-analytic thing is that this test is done on live cells, and hence this must be performed within the first 24 hours. The best results will be achieved if you do it in the first 4 hours itself. You use a heparin tube, that is a green tube, rather than a EDTA tube. So it is not a usual sample. You have to pre-inform the lab if you're doing or planning to send a sample of a basophil activation test. And the sample transport should be within 24 hours. It should be stored at 4 degrees Celsius at room temperature, leads to much faster decline of the cell life. So has to be sent across in cold ice tubes. The negative control is usually a buffer. So this measures the spontaneous activation. It tells you whether the cells in itself, the basophils, are leaky or activated just by handling of the tube. And the positive is as simple. You give an antibody against the Fc epsilon receptor. So this is bound, it will bind to the Fc epsilon receptor that is there, and this will cause activation of the basophils. So this actually tells you the validity of the test. If you have a positive negative control, that means that the test is not right. The basophil in itself are very excitable, and you can easily activate them. Whereas if you see that the positive control is negative, then the validity of test is again questionable, because if the positive control is not responding, there is some problem in the activation of the basophils. And I'm not so sure why my slides are not, the figure that has not come, but you, through your fluorescent antibodies to the stimulated blood tubes, you see it is through the normal flow cytometry techniques that you see whether this is positive or negative. Let me just see if I can. I'm sorry. Somehow the picture couldn't come, no worries. And then there is a gating strategy. So the basophils are usually not a very common set of blood cells. So you use gating strategies to identify basophils well. So the CD123 positive cells would be both basophils and some plasmacytoid dendritic cells. So you can see that those who are CD123 positive and HLA-DR negative. So this would rule out all other cells and only select the basophils when you are finding the basophils. The same method can be used with CRSTH2 positive or the CD193 positive cells. So basophils share some common receptors to both eosinophils, plasmacytoid dendritic cells, and certain T cells. And the negative markers are to ensure that you have no T cells, eosinophils, or other confounding cells that are there in your sample. So what are the clinical applications? So the clinical applications include food allergy. So you could use this for diagnosis of food allergy. differentiating true allergy from asymptomatic sensitization in patients who have multiple food allergens to be positive. You could even use to assess whether the patient will tolerate a baked milk or a baked egg challenge. You could assess the severity of the allergy to a specific food, and you could also use it for monitoring of uh, oral immunotherapy. So, you have a 6-year-old child who has come to you with eczema, and there's no history of eating peanut. He has a skin reaction that is positive. His specific IgE is also positive, and his CID is also showing some ARA-H2 sensitization. Uh, you said that the patient possibly might have peanut allergy, and you wouldn't want to give a challenge right now. But the mother insists that his older brother also has had the same tests and has eats peanut butter sandwiches regularly and has never had any reaction. So the dilemma is whether the patient is truly allergic to peanut or is just sensitized. And this is where the basophil activation test might be helpful. So currently the oral food challenge test is our gold standard, can induce life-threatening reactions, and 50% of these can be positive. It requires a specialized setting, a specifically trained staff, and has a lot of stress that it can give to the family, to the patient, and to the staff itself. So, is there any safe way of deciding whom to send for oral food challenge and whom not to send? So if the bat, you do a bat here and the bat comes positive, this almost confirms clinical allergy with high certainty. And you can avoid a high risk oral food challenge and advise to continue avoidance and prescribe an epinephrine auto-injector. And if the bat is negative, this strongly suggests more tolerance, has a good high negative predictive value. You can proceed for an oral food challenge with a much higher confidence, and you would most likely rule out a clinical food allergy. So case studies have shown that it reduces OFCs significantly. And if you use a BAT screening technique, it reduces the chances of a positive OFC also significantly. Even whether to, so if someone has milk allergy or egg allergy and whether they can have baked foods, this again bat through multiple studies has shown that if someone is negative for baked or cooked milk, uh, you can give them or give a challenge quite easily as compared to not knowing without a basophil activation test. And regarding severity, so there are two things. There's something called as reactivity. That is, what are the percentage of patients' basophils that activated in response to an allergen. So let's say if we have 100 basophils and we stimulated them with an allergen, and 2% got activated or 98% got activated, will tell you that someone has more reactivity or less reactivity. And you could also test the sensitivity. That is, what is the lowest dose of allergen that can trigger a significant activation. And this can help you in deciding what is the possible severity of clinical allergy a patient might have. So more is the reactivity and sensitivity, the more severe chances of a critical reaction being happening, the more chance of anaphylaxis in a patient. It can even be used for monitoring of oral immunotherapy. So it is an outstanding biomarker for tracking biological desensitization. If you have reducing reactivity and sensitivity, you are going on the right direction. And it can even tell you, so this was a graph that actually showed that progressively your with oral immunotherapy, your sensitivity and reactivity reduces, and you can then give a challenge also to see how effective your oral food therapy has been. Now, clinical applications in drug hypersensitivity reactions. So you have multiple drug challenge issues with identifying what is the best way to identify a drug allergy. And again, basophil activation tests help to a great extent. A positive BAT has a very high specificity and will almost confirm a drug allergy. A negative has usually not that great a value, possibly a mast cell activation test might be more significantly helpful in such a situation. So, the problem with neuromuscular blocking agents and perioperative anaphylaxis is we must find what is the culprit neuromuscular blocking agent and also a safe alternative. So, it has both a good sensitivity and specificity to identify a neuromuscular blocking agent and confirming what kind of neuromuscular blocking agent is causing it. It can also test for cross reactivities and find a safe alternative that the patient can be given perioperatively. Even with venom allergies in patients who have both VASP and B sensitization that is positive, you can use it to identify the correct uh, insect that is causing it. In patients who have IgE negative anaphylaxis but have a very strong history, you can use a basophil activation test again to identify which of these is causing it, and you can even use it to monitor a venom immunotherapy. So CCDs, as we know, are the major agents that actually cause double positivities in a lot of patients with both VASPs and Bs. And basophil activation does not depend on CCDs to degranulate. So it can actually filter out the CCD noise and identify the true clinically relevant allergy that is there against the relevant insect and help you guide what venom immunotherapy is to be given. Uh, and even in patients who are both skin prick and IgE negative, usually 75% of patients come out to be BAT positive, offering you a a significant chance of finding what is the allergen that is causing the patient's anaphylaxis or severe reaction. And even in chronic spontaneous urticaria, we still don't have an exact test that differentiates whether this is the type 1 autoallergic spontaneous urticaria or the type 2 autoimmune spontaneous urticaria. And BAT might actually be an answer to identifying the correct set of autoimmune spontaneous urticarias in these set of patients. And this would be basically by so you would take the patient's serum and someone else's, a normal person's basophils, or you could take basophils from culture and see whether the patient's serum activates the basophils or not. If it is activating, it possibly has antibodies against the basophils in the patient's serum. And this is a much more simpler way of doing the autoserum test that we often do, because the autoserum test can have other corollaries also, and that might be one of the reasons that it hasn't found a lot of favor over the years. But a basophil activation test, this is not a direct one, this is an indirect one, can offer you significant answers of what kind of urticaria this patient has, whether this is autoallergic or autoimmune. So this is all of what we have discussed. It has multiple roles in food allergy, in drug allergy, in venom allergy, and in chronic spontaneous urticaria. It can be used to avoid high risk oral food challenge, can help you in guiding safe dietary expansions. It can help you in monitoring the efficacy of OIT. It could be a very good rule-in test for drug allergies. It could identify culprit agents, help you rule out cross reactivities, confirm the diagnosis of venom allergy, identifying the right sensitization and the right response to immunotherapy, and confirm a autoimmune variety of the chronic spontaneous urticaria. It is not an excellent test possibly because it also, like all things good, have some limitations. It has a non-responder phenomenon. So what happens is, some certain basophils, the spleen tyrosine kinase causes down regulation of its receptors, and you might not get the kind of activation you would want. It is not just the basophils that cause allergy, it is also the mast cells, and you might not find all the answers with the basophils in a patient's serum. The major limitation are its logistical limitations and the variability that is there. So you have the sample that needs to be run as fast as possible. You need trained staff and a setup that has flow cytometers, and you have regulatory limitations. The But still not, there's not a single basophil activation test that is FDA cleared till now, because there is a lot of variability in which how everyone does basophil activation tests. So about 10 to 15% patients are non-responders, and this is because there is internal signaling downregulation by spleen tyrosine kinase. This does not mean that the patient is not allergic, but their basophils are a little less responding as compared to a normal basophil there, and this is a normal variation. The next and the most important is requiring the time and the complex methodology. And this ensures that this is not as cheap as possibly a skin prick test might be, or as easy to do as possibly a serum specific IgE or a CRD is, and requires trained people both to do it and to interpret it. And the standardization. So people use different gating strategies, use different markers, different concentrations. I think there are EACI efforts going along to ensure that there is consensus in protocols and quality assurance. But till that comes about, there are certain variations. Every country, every lab that does basophil activation has its own set of protocols, and that is something that limits it. So, though it is a highly specific test, a functional assay, almost no risk to the patient, useful monitoring tools, solves key dilemmas. It has all of these problems regarding non-responders, lack of standardization, logistical issues, high cost, and regulatory issues that is still persisting. So, what can be an answer to it? Possibly a macrophage activation test, a mast cell activation test could be a possible answer. And like basophil activation test, here again you would see features of mast cell activation. The problem here is, or the advantage here is, you are not using patient's own mast cell. You are actually using cultured cell lines. Either these could be because from the mast cell leukemia cell lines or a usual mast cell culture cell line. And this is very important if you want to see the MRGPX2 activation, which these receptors are not present in basophils and are exclusively there on mast cells. And if this is a pseudo allergy caused by the MRGPX2 receptor activation, it is only through the mast cell activation test that you'd identify this. So in basophils, you take patient's own basophils, whereas in mast cell activation test, you take mast cells either from leukemia cell lines or from healthy donor culture cells. Use do the same thing as you do it with the mast cell basophil activation test, and you see whether there is activation there or not. The advantage here is this is not time dependent. Because this is from a source that is outside the patient, you can do it even in long time. We don't have a lot of long-term data, but whatever data we have from mast cell activation test, the number of non-responders is significantly low. It is much more costlier right now, but the technical execution is much more simpler, and you do see a significant amount of response that you have here. Standardization and variability is an issue with all of these tests, and but a combination of possibly a mast cell activation and a basophil activation can actually give you a significant amount of answer. The cost again would be another issue. So what are the future techniques that might be used to solve all of these issues? So you have the dry reagent kits, or where a pre-mixed dry tube is available, and this ensures that this dry reagent kit is available at all centers that are testing it, and ensures that there is standardization by removing the variability of the testing kits itself. What are microfluidics? So these are single cell analysis techniques. So each cell is passed through a tube of a flow cytometer, and you can test individual cells very effectively. The problem is, because basophils are very few in the serum, that in the blood that a patient has, there are multiple issues when you're reading it on the flow cytometer. And single cell fluidomics or microfluidics ensures that there is much better reading of those basophils. And multiplex BAT is again a technique where you can use multiple allergen testing. So it is like a CRD of BAT, where you can, let's say you want to test for milk allergies, you'll again test against multiple allergens at the same time. These would be in chips or tubes that would be slightly more complex than what a CRD does, but will give you those significant answers regarding actual allergy in a patient. So, coming to the end of my slides, what is basophil activation test? So it is a functional challenge test inside the tube uh, that measures clinical reactivity and not just sensitization. Why is it needed? It avoids high risk challenges, and often in patients who are negative or have a lot of polysensitization and complex issues, give you significant answers without doing very high risk procedures. The limitations are regarding the time and the lack of standardization and the cost and the methods that are required. And there is a lot of potential in the future. We are getting uh, lots and lots of newer things in the lab that might improve how a basophil activation test is done and how it is interpreted progressively. I think the best answer of how what the future, what basophil activation test would have is 5 years before today, if someone would have asked me, would artificial intelligence be this big in our life after 5 years, I would have thought that this would still be a thing that you would see in movies. But you see how artificial intelligence is so critical a part of our lives in just the last 2 years itself. And the leaps and bounds at which technology is going forward, we possibly will have a lot more ease of doing basophil activations as we go along. This is an excellent test. It just needs a little more uh, fun, frolic, and ease of doing it progressively. So, thank you so much.
Thank you, Dr. Kunal, for that excellent overview on this much topic, which is not so well known by most of the practicing allergists, or this probably we are not using it regularly, but you did definitely gave a very crisp presentation on this and made it look simple for all of us, though. And just to add that Dr. Kunal, I missed it, that Dr. Kunal is currently practicing in Zydus Hospitals, Ahmedabad. He was previously working at Lucknow. Yes. And Dr. Kunal, which centers are doing this test currently, if I could ask that?
So in India,
In India?
I don't think anyone is doing it at research stages also. Uh, a lot of centers in Europe, Australia are doing it. Not anyone right now in India. If someone has a specific research interest, a few of my mentors do it in Australia and in the European countries that I have. And I could probably connect you if there's a dire need of sending a sample across. The problem again is the transport needs to happen very fast in a solution
Yeah.
that is specific. So
Is that because the T half of basophils is quite
yeah. In
less,
itself, you're
almost
asking
6 hours?
yeah, so you're asking a cell to survive in a solution outside the body. A cell
Yeah.
that is again very few in number. So for a T cell, if you lose some cells also, it is still okay because you might have a lot of T cells or B cells there. But for basophils, it is again an issue.
Yeah. And the transportation, then, even if we are going to send it from here abroad, then, I mean, how is it going to be practical?
Yeah, so that's again an issue.
Correct.
The patient
And
has to have a lot of money probably. They can go directly to the country that is doing it and get it done.
yeah. And even in autoimmune, I just had a doubt in autoimmune urticaria, like you said,
Hmm.
that the patient, it should be against the patient's own basophils, right? And
So in what we do in autoimmune urticaria is we take a healthy basophil, and what we are
okay.
wanting to test, we are wanting to test whether the patient's serum has antibodies against mast cells or basophils or not. Whether they have against the Fc epsilon receptor or Fc gamma receptors any antibodies in their serum. So if the
Okay.
patients will have those antibodies in their serum, they'll activate the healthy basophils also. The
Oh,
basophils,
it's not just the own basophils.
no. So
Yeah.
it is, that is why it is called as an indirect basophil activation test, because you're testing whether the antibodies are activating it or not. So what it does is it will tell with quite, because you don't know what all antibodies can activate a basophil or a mast cell in the type 2 CSU. So this in itself reduces your possibility. So this is like a, so for a rheumatologist, this is more like an ANA. It will tell you whether there
Yeah.
are any anti-basophil antibodies or not.
Correct. Uh, Neeraj sir, anything from your
Neeraj, I
side? Any?
think he has put two questions.
I'm not able to see.
How do
Huh.
you
Add allergens. Yes.
So they are not usually commercially. So that is the problem, sir. They are not commercially available. So the same allergens that you use for testing, possibly in a CRD, you take them in variable concentrations. Now each lab also decides its own set of concentrations in them. And what you do is, in a tube where the basophils will be there, you'll add these allergens, keep it for a certain amount of time. That time is also variable based on the lab that is doing it, and then see whether, based on exposure to these allergens, whether there is activation of these basophils or not.
Yeah. And any prerequisites like any period of being off antihistaminics or steroids or omalizumab or any other drugs before the test?
Antihistamines is a no-no. You can be on antihistamines because that won't affect the basophil in itself. You're taking it out in a medium that is outside. Uh, you can test it. Regarding omalizumab, I'll have to check, because possibly these patients that are the basophil activation tests are done before starting of therapies in the centers that they are doing. But again, the anti-Ig antibodies don't block the receptors that are there on the basophils and mast cells. So theoretically, it should not be an issue. But again, I'm not the expert who does it very frequently, so I'll have to possibly rely on one of them when they come
Why
to.
I am asking about omalizumab is because it is said that if you are doing a skin prick test, then
Yes.
ideally omalizumab they should be off 6 months of omalizumab and then you should do. The other thing is that like when you are using omalizumab in chronic urticaria, then at that time omalizumab is like after 2 or 3 months it causes internalization of
Hmm.
your IgE receptors and all these things. So if they are causing internalization of IgE receptor, then if it is causing the same thing on mast cell, it might be having a similar effect on the basophil. And then at that particular time, if it is acting through these Ig receptors only on the basophil, then that's why I just thought that is there any prerequisite or not?
So for CSU, if you are a, so what my discussion has been with the university in Berlin, the Charlie University that is there, and they do a lot of work on mast cell activations and urticaria. So they have now started doing this indirect basophil activation test before deciding most therapies. So if you are BAT positive, your chances of responding to omalizumab is much less. So you would in turn have reduced possibility of being a good omalizumab responder, and here you might be a good candidate for either ramibrutinib or dupilumab in their line of this thing. For us, if someone is actually a bad positive for chronic spontaneous urticaria, they might be a better candidate for cyclosporin tacrolimus vis-a-vis giving them omalizumab, because that tells that you are more autoimmune than autoallergic in response. So they take positivity of a basophil activation test as a poor response respond predictor for omalizumab.
Can you explain or elaborate this a little bit more? Reason behind, because what I understood with the BAT is that you are telling that BAT is something in which you are actually taking the help of Ig molecules which are sitting there on the BAT, and
No.
then when you are exposing, so suppose if it is positive, that means it is reacting to the allergen. That means Ig is there and it is reacting. So
Yes.
anti-Ig should work.
No, no. So that is for the usual allergies, not for chronic spontaneous urticaria. For chronic spontaneous urticaria, you are testing whether the patient's serum has antibodies against basophils or not. So what you're doing is you're taking the patient's serum out, and this serum would have antibodies in it if this is the autoimmune kind of urticaria.
Okay,
And what you will do is you will react it with normal basophils
normal
and
basis.
see,
Okay.
and see whether the basophils are getting activated or not. So if the basophils are getting activated, there are antibodies against the basophils that are now binding to the basophils and causing basophil activation. So this means that this is not the classical IgE mediated basophil activation that is happening, and hence this patient is less likely to respond to anti-IgE therapies and more likely to respond to other therapies like the ones that the butyl tyrosine kinase inhibitors or dupilumab mediated therapies that are now
Got it.
showing
Got it.
significant.
Yes. Got it. Great. Thank you. Thank you. Thank you. Excellent presentation. Thank you. Thank you.
Thank you, Dr. Kunal. Thank you, Dr. Neeraj, sir. And moving on to the next session, I'm extremely glad to invite Dr. Saibal Mota, sir, for the session on emerging and future testing techniques in allergy. Um, Sir is an adjunct professor and senior consultant in the Division of Allergy and Immunology and the Department of Respiratory Medicine in Apollo Multispeciality Hospitals, Calcutta. Sir is a very excellent and well-known researcher with more than 100 publications to his credit. He's a principal investigator and co-investigator of extramural projects, out of which 9 are completed and 1 is ongoing. I'm proud to say that I'm a student in DAA course, and Sir has taught us so much in the field of allergy as well as research. I welcome you, Sir, on this platform and waiting to hear on this topic from you.
Thank you, Sinchana. So, am I audible to all?
Yes, sir. Yes.
Okay. At the outset, I would like to thank the Pediatric Allergy and Immunology chapter of IAP, Dr. Neeraj Gupta, and his entire team for inviting me in this excellent webinar series. I really feel so good that all the excellent webinar series that he conducts on important topics, and it's really doing a lot of good work for the entire community in the country. Okay, so I've been entrusted to talk on the emerging and future advances in allergy diagnostics. I have nothing to declare in the context of my today's talk. This is Saibal Moitra, okay? So now Dr. Saibal, so he is thinking that ideal scenario would be like if in context of the food allergy we are talking about. So he sees a patient, he advises a test, say a skin prick test maybe, and the test comes out to be positive, okay? And he says, well, this is allergy, okay? So I've diagnosed allergy. And the test comes out to be negative. He is also very happy. He says that, well, it's not allergy, okay? So this would have been an ideal scenario. Okay, so that means we do a test and if it's positive, it's 100% positive, diagnose the disease. If it's negative, it's 100% true, we don't diagnose the disease. But what is in reality? In reality means, even if it is positive, we diagnose only 20% of the case. And if it is negative, there are lots of false negatives into it. This I'm just talking about in case of the food allergies. So Dr. Saibal is confused, like, well, means what am I doing? Or what am I testing? Again, going back to the history, taking another history, correlating with that. So, well, that's a big task. And it's really something, a Herculean task. And, well, I'm really confused. So if you see that even in the context of the food allergy, if we just talk about, usually patients will say, well, I'm allergic to this, allergic to that. So there are multiple suspected food allergies, but there may be no history of exposure even. So we can do the allergy tests. There can be multiple sensitizations. So we just got stuck about with this word called sensitization. Well, Dr. Saibal is a naive doctor, okay? So he just wanted to diagnose allergy. So now from where this sensitization thing has cropped into, well, it's so difficult. So to understand and basically to just take into in his own stride, it's quite difficult. So maybe he does an oral food challenge, which is really a big task. You have just heard Dr. Kunal has so nicely pointed out its difficulties. Even, you know, even in the UK, the best of the centers, there are means the best centers who does the allergy centers, they do approximately 4 challenges per week, and other centers, maybe the secondary level centers, they do 2 challenges per week. So you can understand that it is really, there is a lot of hurdles into it. And so Dr. Sabel is really bewildered. So this burden of assumed food allergy, increased risk of food allergy, what to say, what not to say. So it's a big dilemma, right? So he just wants to know that what is it that can make his life a bit easier? So what's there coming? Do we have anything? So to answer this, let us take a whistle-stop tour of what is coming in all our way. Okay. So this is one of the diagram I've taken in from this Jackie. And when I was hearing to Dr. Kunal's talk, I was seeing that both of us had consulted a few of the similar articles. So here we have is the clinical practice of skin prick testing, the specific IgE to the allergen components. There are lots of things going on in the research. So, but it's all in the bench work, right? So a specific IgE to allergen peptides, and then we have the immunoglobulins, we have the BAT. We have heard such excellent talk about the BAT by him. There's also the tests, T cells, mast cells, activation, all those things. And then we have the future advances of so many big data, omics, machine learning, AI coming into the picture. So, well, the future is not that bad. So let's start with the tour. The first stop is, this also has been talked about by Dr. Kunal, cytobas, or the multiplex X BAT. So here we have the patient's blood, and then we have the allergen tetramers, which are tagged with a fluorochrome. And then we take the patient's basophils, and we have a control of the non-allergic patients. And then the incubated with the basophils, then incubated with those fluorescent recombinant and tetramers, which are bound to a fluorophore. And if the surface binding of tetramers are there, which are assessed by the flow cytometry, and again, to see the activation markers and degranulation markers, CD63 and CD203C. And then we find out that what is allergic and what is non-allergic, and we compare. So we can take the individual molecule like APM1 tetramer or the LOLP1 tetramer. So this is a new thing which is combining the CRD with the BAS, with the basal activation test, what we call a cytobas. And basically it's known to improve the sensitivity and specificity of the CRD. And along with it incorporates the basal activation test. So next stop is we come to a mast cell activation test. We have seen that basophil activation test is really a test which is in majority of the places. And now we have BAT coming in a big way in the domain of the allergo-oncology. Okay, so and we know the BAT is coming is there for the drug allergies, venom allergies, the food allergies, and so on and so forth. But one of the biggest hurdles that we have seen for the BAT is it needs the fresh blood. Okay, so that means because the cells has to remain active. So that was one of the big logistical hurdle, because the blood should be tested within 4 hours, or maybe at least 24 hours. So this was actually taken care of at mast cell activation tests. But the mast cells, what is done is that the mast cells are not from the patient's own mast cells. But the mast cells are already there from the various sources. It could be humanized like the HOXB8 mast cells, or it could be some precursor mast cells in the blood, like the CD117 positive cells, which has to be cultured. in a culture medium for around, say, 8 to 12 weeks. And then they become the human and peripheral blood-derived mast cells. Or it could be some other like pluripotent stem cell precursors, which give rise to mast cells, or maybe certain human mast cell lines from leukemic cells, as Dr. Kunal was alluding to, like the LAD2 cell lines. So whatever the cells we use, and the patient's blood is then taken, in serum or plasma is separated, and these mast cells, they are then incubated with the patient's serum or the plasma, which has the antibodies, again, the high affinity IgE receptors. And when this is actually binds to the high affinity IgE receptors, then this entire there's a cell with the bound IgE, they are then incubated with the allergens, which will again bind with this receptor, this IgE, which is bound to receptors, do the cross-linking and cause the degranulation of the mast cells. So what is measured is increased in the activation markers, so like the CD63 and CD107A, these activation markers. At the same time, it also looks for various mediators, which is degranulated in a supernatant end of that system. It could be like the histamine and surrogate, like beta hexosaminidase, or it could be the de novo produced all the various mediators like the prostaglandin D2. So if you see this ROC curve over here, with the mast cell activation, this MAT is quite excellent. If you just see where this SPT lies to the peanut, we see where the MAT, we find the MAT to be a very, very good test. It's a very good specificity because sensitivity is a bit lower, but it's a very good specificity. So this mast cell activation test has numerous applications in the food allergies and drug allergies for the beta-lactams, NMBs, antiseptics, and cannabis. The respiratory allergies like the house dust mite, tree pollen, grass pollen, and the Hemiptera venums, and obviously the autoimmune and chronic spontaneous urticaria. So this is so when we are actually testing these cell-based assays, we are in what we have seen in case of the basophil activation test, we are actually using not the indirect one, the direct one. We're using the patient's own basophils. So where we are testing the two things. One is the humoral marker, the antibodies, and also the intrinsic activity of the cellular intrinsic activity. But here, what we are testing in this, here the cells are not for the patients. Okay, they are from a different source. So here we are mainly concentrating on the humoral components. That is the antibodies. Okay, so here it could be like these are the antibodies we test with. Again, if I come back to Dr. Neeraj's question, like so what we are doing is like in a chronic spontaneous urticaria, now we have two major phenotypes, type 1 or type 2B. In type 1, which is said that it is mainly the autoallergic, we have the IgE antibodies is to the surface markers of the mast cells. Else, and type 2B, we have it is actually autoimmune. We have the antibodies against the high affinity IgE receptors. So high affinity that Fc epsilon R1. So let's say like if a patient is already on the omalizumab, okay, of a chronic spontaneous urticaria, and this omalizumab, we know it downregulates the high affinity IgE receptors. So that is one problem if we do the BAT. But in this, what we are seeing is here the mast cells are not from the patients. It is basically some other sources. And if you're doing the indirect BAT, which we do in case of the chronic spontaneous urticaria, there the basophils has the intact receptors on it. So we are only just checking that whether there is any humoral component which can degranulate that cell. So it could be an IgE, it could be an IgG, whatever it is, it does not matter. So direct BAT is not for CSU, it's indirect BAT, and MAT could be done for the autoimmune chronic spontaneous urticaria. So this is one of the utility that we have seen. So this is a test, and we know that this test does not replace BAT. It is done as a complementary test, the BAT, like in for the 10% of the patients who are BAT unresponders. They're not non-responders. They are not activating because this down-regulated, that is the intercellular downstream the pathway molecule. So in them, the MAT can be done. Next we talk about a very interesting test. It's called a bead-based epitope assays. Now, when we are just discussing about the specific IgE, we know that initially it could be to the whole allergens. Then next we came about to the molecules. And then next we go to the more granularity, that is to the various epitopes. Okay, so against which the IgE can be measured, so the epitope-based assays. So I'm not talking about the microarray immunoassay for the epitopes, but it's a very interesting test. This is what has happened is that, you know, that whenever an allergen, okay, so it can have an epitope which is recognized with the B cells, the B cell epitopes, which are in the surface, which are the conformational epitopes, or there can be T cell epitopes, which are inside, deep inside the allergen molecule, which are the linear or the sequential epitopes. So the sequential epitopes, these are selected, and the selected epitopes are then coupled with the beads. So this is the bead, and this is the epitope. And then it is incubated with the patient's serum. And then the secondary antibodies are added to which a fluorophore is tagged. And then there is the reader, and this is read. And then what we get is the mean fluorescence intensity. But if you see this curve over here, so you can see that in the mean fluorescence intensity and its density, there's a lot of skewness and the curve, and this kurtosis over there, you know? But if you see this Cullen-Frey graph, so it's all means in one corner. So what was done is that there was log2 transformation of this MFI, so which gave rise to the binding intensity, and there it is almost a good curve, and there it becomes it is in the logarithmic transformation gave rise to a good. There's not much of dispersion into it. So it is this measured in this way, and these are bead-based epitope assays. It helps us to give an indication of where the sequential epitopes. So this is mainly for the food allergies or for this as other allergies. So this was validated by this is a two big cohort. Okay, so the children cohort, and the poised cohort. This was done in Stanford. So they have found that, and they have also taken the LEAP cohort for the peanut avoiders, and they have found that this is a quite well validated test which could be used first, and which has diagnostic accuracy of more than 90%. But there's a problem in this, you know. The problem is, if you know that it can measure only the linear or the sequential epitopes. But the allergenicity is not only decided by the linear epitopes, decided by the conformational epitopes as well. So that means conformational epitopes are recognized by the B cell, the linear epitopes are recognized by the T cell, then there's a TB cooperation in the secondary lymphoid organs, which leads on to the formation of the germinal center. So this test only can find out about the sequential epitopes. So how does it matter in relation to the diagnostic paraphernalias? It's important that the sequential epitopes are basically the T cell activation epitopes. And these T cells are the master regulator cells, also the B cells. So if these epitopes are there, so that means it has a very high validation diagnostic accuracy for the various food allergies. And in this case, it was done on the peanut allergies. Next are some of the T cell assays. This is very interesting, you know. We know that the T cells are the master regulator cells. And there is a T cell plasticity in which way the T cell phenotypes are there. And one of the major phenotype, which is important for any allergic reaction, is the Th2A phenotype. And because since this has the surface markers of CRTH2. So this was a study which was an impact clinical trial. So they have taken and the three groups of people or subjects. One is who has a high peanut allergic subjects, the low peanut allergic subjects, and those who have sustained unresponsiveness post peanut oral immunotherapy. They have found the high peanut allergic, usually they have the high Th2A. The low peanut allergic, they have a low Th2A, rather more of the Th1 and the Th2 subsets of the T cells. And well, those who are unresponsive to post peanut oral immunotherapy, they don't have any Th2A in the periphery. So this was very interesting. So it has shown that the T cell assays, which actually picks up the various types of the T cell phenotypes, can be used not only for the diagnosis, but also for the risk stratification and the response to the oral immunotherapies. So this was a very interesting curve, which shows that, as I was talking about, that the T cell are very plastic cell. They actually changes over a period of time, depending upon the cues or the information it gets from the antigen-presenting cells, which we talk about are the dendritic cells, and also in the milieu in which it is activating. So this has showed that if you see this curve, so those who are at Th2A high toddlers, so over a period of time, this Th2A, the cells remaining quite high. But in those at Th2A low toddler, you can see this Th2A is very, very less. But there are other cells also which are like Th1, the H17, and all these cells are more common over there. So this helps us to understand and what are the trajectories is these patients, the children will have when they're undergoing the oral immunotherapy, or what is as the T cell map they have for the diagnosis of food allergies, which is more clinically relevant, and it's not mere sensitizations. Next, for the cell-based assays, we have the B cell assays. B cell assays is still it will take time to come up because when after the blood collection there is a mononuclear cell isolation, then the B cell enriched Buffy coat is taken, and there is single cell sorting with a single cell PCR with a Sanger sequencing. So there it has been found that those which are IgE positive B cells, also they are more in individuals else who are allergic to a particular allergens. And it is not only that, it could be like IgG1 positive memory B cells. If it is high against a particular allergens in a particular individual, it shows that this memory IgG1 positive memory B cells, they get switched to the IgE on activation, and they produce lots of IgE. So presence of this type of the B cells, else either in the secondary lymphoid organs or in the peripheral blood, it shows that they are quite allergic, tend to be more allergic. It's not sensitization. It's really we talk about the allergies and which can give rise to the signs and symptoms when exposed to the particular allergens. So if we just do a recap of the cell-based tests as what we have studied so far. So, well, currently we have history, specific IgE testing, we have the skin prick tests, we have the oral food challenges, we have the CRE. But here you have just heard about Kunal's excellent BAT talk. Then I have just tried to show you how this MAT is another test, which is there in the pipeline. There's a bead-based epitope assays, which you also discussed, and there's very interesting T cell activation, though this is much less utilized, and maybe it'll come up before the the B cell assays, the food allergens, and then they see that it is incubated with antigen-presenting cells and the T cell is taken from the patient system. and is the cytokine release, namely the interleukin 4, 5, 9, 13. That is the signature Th2 cytokine and its acid in the supernatant. So that this is a T cell activation test. So this is the various emerging tools diagnosis of food allergy with the application in the other allergies as well. Next is the cytokines. We talked so much about the various cytokines which are released. So does this have any importance or any role in as a biomarker for the diagnosis of allergies? So we know that the cytokines, they're released from the multiple sources. When we talk about epithelium-derived cytokines, it could be IL-33, 25, eotaxin 3, or we can have like the Th17-derived cytokines is IL-17, then the Th22-derived cytokines, IL-22, the Th2-derived cytokine, the TARC, IL-4, IL-5, and we have the pro-inflammatory or anti-inflammatory cytokines, IL-6, and so these are there. So measuring and the cytokine is quite an important and biomarker which can give the evidence of the allergic phenotype in a particular individual. But there is a catch in this. If you see that these cytokines, they can be released from the multiple tissues. So when we're talking about in the context of a diagnosis of a particular disease, we know that IL-28 can come from the lungs, it can come from the skin, eotaxin can come from the skin, from the sinuses, from the gut, from the esophagus. So there's a considerable overlap between the source of these cytokines from the various organs. So actually, this is one of the hindrance which actually diminishes its utility in the diagnosis of the allergies, but it is an add-on test which definitely helps to understand the allergic milieu in a particular individual, in a particular context. No, I think, yeah. So this is very, very important. Okay, that is the microbiome analysis. Now, it's not only that we are looking into the host factors, we are looking into very, very important, the microbiome analysis. And microbiome analysis is going to hold a very important role in the future allergy diagnosis. Because we understand as of now that we are what we eat. And what we eat decides our microbiota. So depending upon what is the microbiota, it actually helps us to understand whether this individual is going to have an allergic phenotype, or if this individual is going to have a non-allergic phenotype. So this was a very interesting study, and which was published in JACI in 2022, where they have looked into those which are high threshold for the peanut allergies, like one or more peanuts, they need to have a reaction, or maybe much less amount, like 3 milligrams, less than 3 milligrams for reaction as a low threshold individuals or not allergic. They have looked into their oral and the gut microbiota, and they have seen that like there's a lot of microbial signature differences in the two groups. And like maybe the Veillonella is more common in the oral in those who are non-allergic, and maybe Neisseria is more common in the oral microbiota in those who are allergic. So what does it pertains to? It pertains to that even if an individual has all the other phenotypes or maybe the endotypes for an allergic disease, but if the microbial structure which actually promotes a non-allergic, a constituent in the particular individual, the person won't manifest the disease. This is also an adjunct testing modality, which is coming in a big way. And if you understand that nowadays, when we talk about the microbiota, we talk about so much about this alpha diversity or the Shannon index. Okay. And there was a very recent paper, such an interesting paper. Okay. It was showing, it showed that it's not only the specific bacteria we are talking about, it's not only the amount of that bacteria or the diversity that we're talking about, it's also about the various interactions between each of these as bacteria in the particular niche, which is very, very important in actually having a particular phenotype. Well, that's all coming up, and we'll be having more and more or evidences so that it comes in a big way to understand allergic phenotype. So everything now we know that it's an omics era, which we're ushering into. We talk of not only the genomes, we talk of the RNA transcriptomes, or the proteomes, or the metabolomes, and integration of the omics into the patient's diagnosis, which is allergy and immunology, is something, it is an emerging tool. So here comes the challenge. Challenge is it is not only omics data, there are lots of non-omics data which is there. It is about the patient's clinical history, patient's epidemiology, patient's demographics, and this integration of the omics and the non-omics data, which can be various modeling types, like the joint or the conditional or the independent modeling. It gives rise to a specific disease outcome in a particular individual. And to understand that, we need to have it integrated data and also non-omics data into one. And though there is still, we know, there's a high heterogeneity, there's large scale data, there is big data, there's high complexity, there's lack of standardization. But this was a big hurdle. But it is not a big hurdle anymore. Why? Because we have already entered the age of the AI. So artificial intelligence is a game changer in the allergy diagnosis, as like of any other diseases. So now we have enormous amount of data. So enormous amount of data from a patient is coming up in the form of the electronic health records. Now they wear so many wearable devices, and we have the multi-omics data coming up, the environmental sensors about the pollens, about the quality of air, about temperature, humidity, and all this environmental data. And we have registries which all can be now such huge volume of data, they can be actually amalgamated into various algorithms. And like we always use the means the logistic regression statistical models. So, but now we have actually now we have the scalable and also very big independent and algorithms like the K means clustering, which definitely it reduces the chances of the bias in the entire ensemble of the diagnostic paraphernalia. And with this, it helps us to understand in a very, very precise manner about the allergenicity and the disease and the various trajectories that it might take in a particular individual. So with all the machine learning algorithms which has come up, it helps us to diagnose the allergic disease as allergy and immunology like other fields in a big way, and which could be used not only for supporting a clinical decision, but also for the research and population health and the other studies as well. So just a small example, if you see that this is say the allergen structure, and this is also with that as structure, it writes a graph. And then, and for this a new protein, so we say that the patient is taking this particular protein, whether it will form allergy to not. So there is a graph neural network, and this gives about hypersensitive reaction probability. So all this, it could be a cumulative neural network, or it could be predictive neural networks. So all this is neural networks are the algorithms which are being now more and more, it has been ushered into the patient's allergy diagnosis. And you will see, as Dr. Kunal was alluding to, that even in the next, say, I would say in the next 5-6 years, there's so much of the AI being used for the diagnosis of the allergy. So if you see that what are the kind of recommended tests, that's the BAT, we have the SPT, and we have molecular allergology. All this data could be amalgamated into the AI, which should help in the clinical decision making along with detailed history. But more research is needed before the recommendation is the mass activation test and the bead-based epitope assays. And now the exploratory approaches which are coming up, T cell assays, the B cell assays, the microbiome assays, and the plasma cytokine. It's all moving in this direction. So now we are over here with all these things coming. And so this helps us what the future is about precisely diagnosing allergy and not a surrogate marker, which we call is sensitization. The test revealing the functioning at molecule level gives a better understanding of the disease process in the individual. So integration of the multiparameter data is a key to understand a particular phenotype in a particular patient. And as I have said, AI is the game changer in allergy diagnosis. So I think Dr. Sabel is happy now to some extent. And I thank you with this photograph. So this photograph, we're curious to know that what I have put over here. This was a photograph which was just published in the Hindu yesterday. Okay, so this is a NASA photograph which was taken by the Webb Space Telescope. So this is a very big star forming, active star forming zone in the Milky Way galaxy in which we are, and it's quite near to the central black hole. And you know what is this called? This is called Sagittarius B2 molecular cloud. Now you would be thinking that why did I put this photograph in this talk of this emerging and the future diagnosis for the allergy? This just to have a small sublime idea. This is where everything is taking birth. It's a molecular cloud. And these molecules are then impregnating each and everything in the universe. And so more and more we understand the granularity of these molecules in a particular individual in way in which it is interacting to form health and to form disease. We get a better precise entire picture of what is happening in that particular patient. And I think this is where we are heading to. Thank you.
Thank you. Thank you so much for that excellent session. I'm sure no one could have done it so well. And you have definitely sensitized us into this era of precision medicine, where we now know that just talking about skin prick, specific IG is not enough. And we are moving quite fast in this technologically driven era and a lot of research going on. So, sir, yeah, there are no questions in the chat box. I would like to
Can I ask
invite
one?
upon. Sorry, yes.
Yeah, so excellent talk, sir. Amongst all of these newer tests that are coming up, what would you bet your money on? So, what do you think is the next big thing in allergy?
Yeah, as you Kunal. So with all these things coming up, so as I've said, that even if what we have now, I would bet my money on the AI. Okay. Because that is going to be really revolutionize the entire process. Because if we see that even if we talk about the cytokine analysis, or if we talk about say the T cell activation assays, or we talk about the epitope assays, okay. So until and unless they are seen in the context of the entire picture, we don't get to see the picture. They are just the bits and pieces. To see the entire picture, it has to be amalgamated. And this amalgamation is best done by the AI algorithms. So even if what the data we have, so we take such good history, such prolonged history. Well, these are clinical data, very important. We have environmental data. Even if we have the CRD with that, the skin prick tests, okay, we have that. But if these data can be amalgamated all together and we understand the picture, we understand the disease better. So AI is something which I would like to bet upon, and I would like to invest my money into that. Okay.
Thank you, sir, for that. I think, but definitely the homework that is that history taking, everything, all the efforts has to be done by the allergists, and then finally we have to put in everything into the AI and then wait for an answer. So the history taking will definitely always have its
Always,
True.
always,
Yeah,
always.
correct. And maybe I don't know, sir, but will it create confusions? But the AI, like the other day I was discussing, then probably someone was saying we have to also write as what will the allergist GDs be? Maybe that is what the question we may have to put.
No, the newer algorithms which the AI work upon, they are data driven. Okay. You do not have
Okay.
an idea on the basis of which the AI is working. But the newer machine learning algorithms are data driven. The data they get, they just work on that and they just give the picture. So they do not, so like in even there's no bias into it. Like all this the unbiased algorithms which has come is all they're actually innovating depending upon the data. So it's very fluidic system, you know. It's not a static system. It's very dynamic fluidic system we have. So the data they get, they just adjust to that, and they just come up with the pictures. That is how it is. So that's how it should be. So like the every algorithm should be actually driven by the data which it is getting. Okay, it is not that it should have fixed ideas. Then we get biased. It's an unbiased the data driven, scalable, actually system which gives a better understanding of the patient's and disease perspective for the particular patient.
Thank you, sir. I would like to invite Dr. Neeraj Gupta, sir, the chairperson of the Allergy IAP Allergy and Applied Immunology chapter, to give his remarks and address us as well.
Thank you, Dr. Sanchana.
For the-
I think after listening to today's talk, and especially after Dr. Sabel's talk, means like I am personally feeling that at least I don't know anything about allergy. I will start once again from the ABC.
No one knows.
It's like it is
Yes,
something
that's
means
true.
like
I
I do not
started
have any words actually. Means
I
like
started with Sabel itself. Dr.
I,
Sabel was there.
I
He
understood.
doesn't know
Understood. But
anything.
I do not have any words. And it is not only Dr. Sehgal. What I want to say is that if you just see the entire picture, and if I imagine myself, what I am doing, I am just taking probably some history, I am just taking doing some skin prick, I am just doing some specific IG, some component. We have yet not started bat. And he has moved from bat to mat and tat and then so many other things. And then it means like I really don't know that what is happening, where I am. Means I am probably somewhere around two centuries back. Somewhere means like something like that. I really don't know where I am. So I am actually lost today after his talk. I mean, it's like I really don't know that what is happening. And regarding your AI, so means like what I personally feel is that yes, I am a very new person in the AI. So the question is that will AI replace an allergist? So I will say the answer is no.
No,
But an allergist with an AI will definitely replace an allergist without AI.
that's true.
So so that is needed. That means AI will be our companion, and we need to really, you can say, like now get a good, you can say, like tolerance to AI rather than allergenicity to AI. And it is always better that if we get a friendship to AI as soon as possible rather than, you can say, like fighting with AI. But means like I personally feel that in past 1 year whatsoever webinars we have done, but today was something different. Means like it was like skin prick patch, everything was like to the dot. And now then Dr. Sabel came, and then I don't know, it's like beyond which I don't know really what has happened actually, sorry. Yeah. So I think we have come to a very beautiful, means like end of a very beautiful webinar on this very important talk, which is on skin prick test, started by Dr. Raja. Very well explained, very beautifully explained. And then Dr. Deepti. Dr. Deepti is something like queen of patch testing, queen of contact dermatitis. I can't see anybody better speaking, discussing, telling, demonstrating about patch testing than her. Means like I cannot really imagine any name. I have tried actually several people, even dermatologist also, but means like the way she teaches, the way she commands that patch test, means like I do not have, you can say, like any words of you can say like extra praise for her. And then I think bat is something which has been, you can say, like knocking our doors, and in every conference, every time, bat is something which is like everybody wants to hear. And that's why I wanted to allocate it to a person who actually can, you can say, like bring Bollywood and Hollywood and everything together on the floor. So, and I thought that let me give this topic to him, and I think he did the perfect justice. And even I also learned few things, and we would like to start bat at Gangaram Hospital. Let's see how the things go. We are still planning to means like do for past few months, but we'll definitely try to push this here at Gangaram Hospital. Let's see how the things go. And then Dr. Sabal is Dr. Sabal, means like there is no match to him, and definitely we all are here to learn from him and learn from each other. But definitely he is having a distinct vision, different thinking. He's a different level. There is no doubt about that, right? So, and he has actually given us a glimpse, and it is actually the right thing. With the last photograph, I really liked, and I really feel that in the entire universe, and when we are talking about universe, it is not only universe, it is multiverse. So when we are talking about all these things, where are we? Where am I? Probably nowhere. So he has actually shown the true picture, that we should not think that, oh, we are at this. We are actually nowhere. There is so much way to go, and the time is very limited. The time is very limited, so we need to, you can say, like, tighten up ourselves, uh, do as much as possible, try to, you can say, like, do whatsoever you can do, and he has actually shown the glimpse of that. So I really liked the things which he had done. So I think the stage is really set for the next day, tomorrow we will be discussing about rest of the topics. One is about intradermal testing, and then is the oral food challenge, because food allergy is something which is going to come up, an oral food challenge. And then we will also be discussing about some provocation tests, though they are done less commonly. But let's see what are they. And then a topic which is a little hatke, like drug allergy testing. So we'll be discussing about all these things tomorrow. So till then, I think thank you so much once again, everyone. Uh, I really enjoyed today. Thank you. Thank you very much. Thank you.
Thank you.